Today, polarization is generating our politics and media in an impactful way that oftentimes is repulsive. And that is why I'm so pleased tonight to see three great organizations working collectively on a single goal: to create a forum in which we can watch the passionate debate that we expect in the Senate, a hallmark of our democracy.
The only way to create lasting change is to have that debate, discuss the differences, and find common ground.
I appreciate the chance tonight to at least help model how some of those conversations would go. But generally speaking, the most coveted thing for any bill you file is, can I get a co-sponsor from the other party? It's a highly coveted thing. When people know each other, it's a lot harder to hate each other.
That's part of why I'm excited to be on the stage with you tonight, Marco, is to show that we can find common ground together.
What qualities should the next Secretary of State possess?
Should be from the same state as the president, at least.
Speaking on behalf of three gentlemen of great stature, he should stand at least 6 feet tall and have a full head of hair. I'm here because I believe, as we heard at the outset from our two friends, the former senators, that bipartisan solutions are lasting solutions. We all need others outside our immediate circle and concerns, the day-to-day things that distract us, to push us together.
I'd point out that the Bipartisan Policy Center is not nonpartisan. It's bipartisan, and that's different.
Bipartisan doesn't mean you agree even on the issues, specifically on how to solve them. It means you agree that the process matters to solving these problems. You have to have a process in which they're solved.
That's why I'm here tonight. Democracy is a verb, and it has to be an active verb. And it only remains a democracy if we do it together.
Good afternoon, and thank you for joining us for today's event on digital mental health solutions. I'm Jonathan Burks, Executive Vice President at the Bipartisan Policy Center. The Bipartisan Policy Center brings together leaders from across the political spectrum to develop evidence-based, pragmatic ideas to address the nation's most pressing challenges. BPC Action, our advocacy affiliate, then works directly with lawmakers and policymakers to turn these ideas into action. Our health policy program focuses on advancing bipartisan solutions to build a more cost-effective, evidence-based healthcare system and to improve overall population health. This includes strengthening and sustaining Medicare and Medicaid, accelerating the transition to value-based care, addressing inefficiencies and misaligned incentives, and responsibly leveraging technology and innovation. Today, we are glad to partner with the Commonwealth Fund for this timely event on how digital tools, such as digital therapeutics and AI chatbots, are reshaping mental health care. The topic is an urgent one. More than 1 in 5 U.S. adults live with a mental health condition, and almost 1/3 of high schoolers have poor mental health. Yet only half of adults and less than half of youth receive treatment. This crisis severely affects those moving from youth to adulthood, as a recent BPC survey found that nearly 2/3 of young adults experienced mental health distress. At the same time, advances in technology and innovation are driving an evolution in U.S. healthcare. The availability and use of digital health technologies have increased exponentially since the COVID-19 pandemic, and applications of artificial intelligence in healthcare are growing rapidly. At a time when behavioral health challenges, especially among young people, demand urgent attention, digital tools offer new ways to reach people, improve health outcomes, reduce strain on the workforce, and control healthcare costs. For years, BPC has worked to advance bipartisan solutions to the behavioral health crisis, from integrating behavioral health into primary care, to expanding the workforce, to improving crisis response, to strengthening network adequacy. This year, our Youth Mental Health and Substance Use Task Force released a suite of policy recommendations to tackle these issues. We're also increasingly focused on the interaction of healthcare and technology, including advancing policies to leverage the potential of telehealth, remote patient monitoring, and artificial intelligence to address some of our nation's pressing health challenges. Today's discussion brings together these two critical areas of our work, behavioral health and health innovation, at a time when digital tools are reshaping how people access mental health care. As use expands, federal policymakers are considering how to regulate and pay for these solutions. Today, we'll explore how digital mental health tools are being used, what we know so far about their value, the risks they present, and the key policy decisions ahead. Now, I will turn it over to Rachel Newsom, Senior Vice President for Policy at the Commonwealth Fund.
Thanks, Jonathan. We appreciate the work that BPC has done in both the behavioral health and tech spaces, and we're proud to support this discussion today. The Commonwealth Fund is a nonpartisan private foundation focused on ensuring access to affordable, equitable care for all Americans. We work to measure and track the performance of our healthcare delivery system and to identify areas where policies could be useful to improve health outcomes. Our nation is still in the midst of a mental health crisis. Mental health and substance use disorders affect millions in the United States, reducing productivity and increasing overall healthcare costs. Significant barriers to care include cost, coverage, and provider shortages. The term digital mental health tools, or DMHTs, refers to apps and tools that aid patients and clinicians in managing mental health conditions. These tools could play a critical role in addressing workforce shortages and ensuring access to behavioral health services. At the same time, there are challenges to widespread adoption, such as unclear safety, efficacy, and privacy standards. Our current regulatory framework is not nimble enough to keep up with the rapidly evolving world of AI and other tech advances. There's also a lack of coordination among federal agencies, with variations in evidence requirements complicating development, approval, and reimbursement pathways. Finally, sensitive mental health data included in these tools raises privacy concerns, especially with AI use, and existing regulations may not fully apply, necessitating clearer guidance and consumer awareness efforts. There is much that can be done under existing authorities to enhance collaboration across federal agencies, streamline reimbursement requirements, and improve privacy protections to support safe and effective DMHT use. We have a terrific panel with us today to help us delve into all of these topics and more. We'll begin with Dr. Tom Insel. Dr. Insel has long been a national leader in mental health research, policy, and technology, having served as the director of the National Institute of Mental Health for over 10 years. More recently, Dr. Insel led the mental health team at Verily and has co-founded 5 mental health startups. His most recent startup, Advocate MH, is a public benefit corporation that seeks to change the ecosystem of mental health by building a marketplace based on quality. Dr. Insel is a member of the National Academy of Medicine and has received numerous national and international awards, including honorary degrees in the United States and in Europe. And with that, I'll turn to Dr. Insel.
Thank you, Rachel. It's a real pleasure to be here and really delighted to be able to have BPC and Commonwealth Fund together help us focus for a little while on this question of how do we approach the digital mental health universe. It's a relatively new industry. We've had this really for about a decade, and it's still evolving. And we have with us today, I think, a terrific panel to help us think about the next set of challenges. I'm going to be your appetizer before the panel. We'll take about 10 minutes here to just kind of lay out the context and some of the things to think about. It should be said that this is absolutely a bipartisan issue. It's one that I think affects everybody. And as Jonathan said, it's a far more common problem than many of us have realized. And it does need all of us working together to come up with solutions. I'm going to share a set of slides with you, and we can have those brought up now and begin to kind of walk through what I think are the promises, risks, and possible policies that we want to think about. Let's talk about where we are in 2025. And it's important to recognize first, what's the problem we're trying to solve? We are in a national mental health crisis. It's actually a trifecta. It's 3 things. It is the youth mental health crisis, which you've just heard about from both Rachel and Jonathan, but it's also the SMI, our serious mental illness crisis. It's the substance use disorder, addiction, SUD crisis as well. Collectively, they are responsible for about 250,000 deaths of despair, which is just an extraordinary number when you just think about mortality alone. It's not only that mortality, but the fact that the costs are increasing with these dire outcomes, and the fact that when you begin to talk to families and patients, as well as providers and payers, ain't nobody happy here. This just isn't working for anybody. We need to look at how to innovate, how to transform, and how to change what we do. The most important thing I'm going to say in these 10 minutes is that this crisis is entirely avoidable. we don't need to be here. If we can get the policies right, we can get the reimbursement right, and we can get the care system right, there's every reason to think that the youth mental health, the SMI, the SUD crisis can be resolved. Huge promise to do that was, as you just heard from Rachel, this shift to the digital mental health world. The whole hope was that through both private and public funding, we would end up with a way of approaching this set of problems with more democratized care, with increased access, with a more convenient system that could scale to really change the numbers. And that is to bring down morbidity and mortality from mental health conditions. The reality is that while that industry has been productive with huge amounts of investment and a few unicorns, there's really no, so far, demonstrable impact on public health. There are very good companies doing very good work, but overall, we're not seeing the reduction in suicide, the reduction in morbidity and mortality that one might have expected a decade ago when the opportunity first presented itself. Raises the question of why? Why have we failed here? And it's not a single thing, but I'll suggest 4 potential reasons why we haven't done better. Certainly, we have not focused enough on quality and outcomes. This is an industry that's mostly focused on how do we increase access? How do we get to scale? How do we get to an ROI? That might have worked well for the business side of this, but for the need to actually get better outcomes, we're going to have to measure outcomes, and that doesn't happen in this space for the most part. We don't have a regulatory framework. Generally, when we think about regulation, we think about consumer protection, super important. But in this case, it's not just protecting consumers, it's giving developers and payers the kinds of guidelines and the kinds of goals that they need to understand what to build to. We found this in biomedical research generally, that whether you're talking about recombinant DNA or the development of small molecules for drugs, that it's regulation that actually helps developers to know what to build for, what success looks like. And we lack that in this industry. It's also the case that most of what's happened in terms of innovation and the development of new companies has neglected the biggest part, the deep end of the pool for the public health need, which is the serious mental illness and the substance use disorder issues. Medicaid has largely been left out, although with the new physician fee schedule that was released last week, one hopes that that may change going forward. And finally, this is a tough area for the development of innovation. It's very hard to get engagement. It's very hard to get the reimbursement you need. The world of healthcare works on a very slow time domain compared to what we do in the world of startups. All of those things, I think, contribute to why this has been such a tough slog for an industry that had such great promise a decade ago, and then maybe even 5 years ago with the move to telehealth in such a broad way. It seems now that with Gen AI, we're kind of in the next act. We'll call it the second act of this narrative, and maybe that actually will be the tipping point. There's every reason to think that new companies being founded that are using Gen AI are going to be able to move forward with a lot more efficiency, with better measurement, with improved quality. Won't go through all of the different tools that are available, but there's no question that we're in a very different moment with the opportunity to use tools that were hard to even imagine a decade ago or 5 years ago. In a sense, it may be useful to think about the analogy of what we do in the world of navigation, where we went from, if you needed a ride, you'd call a taxi and hope they'd show up, or maybe go to a taxi stand, to a world in which you have people with actually less experience and training using GPS through Uber or Lyft to be able to navigate you to where you need to go, to a world where maybe we'll soon have those self-driving cars the way we have in San Francisco and Phoenix and a few other cities that are able to do this all on their own. The question, of course, is, are we at that point now, and how do we manage this both in terms of safety and effectiveness. Let's talk about that for a moment. What are the risks and why do we need this regulatory framework? We do have, I think, for the digital mental health industry, what remains as sort of a Wild West, where you see companies that are mostly spending their investment on marketing and not on optimizing care. The absence of a North Star, the absence of a clear set of outcomes that we're all shooting to, and even an agreement about what are the measures that matter is a problem in this space. And it's what keeps us from shifting from a fee-for-service world to a healthcare system based on value. It's also the case, as was already mentioned, that there are safety issues that we need to think about, whether that's the protection of privacy or making sure that companies have escalation and de-escalation protocols as we deal with crisis. And then the integration with medical support, which is going to be critical and maybe even more difficult to do online than it has been in the brick and mortar situation. Finally, we've got a new challenge, I think, and an urgent one to deal with this, the advent of AI. There's the recent data suggests that when you ask people, how do you use generative AI tools, therapy has emerged as one of the most common uses of these technologies in the United States. I think it's really important for us to understand what that means and what it may include as a risk. There are many things that these tools can do in terms of providing support and advice, but they are really trained to provide answers, to provide advice, to provide support, to tell people what they want to hear in a way that is essentially affirming for people. That's not what psychotherapy is. Psychotherapy is a process that's really about challenging people to change their behavior, change the way they think, change the way they feel. That is a far cry from what you get from today's generative AI tools that were developed for a very different purpose. And that really does lead us then to think about what are the policies that we need to think about. I'll divide those into those that have to do with the digital mental health industry and those that have to do with this new urgent issue around AI. For digital mental health, we are going to need a regulatory framework, but who's going to do this is still, I think, very much a question that we need to answer. I don't think that FDA is necessarily the right way to get this done. It's just got a different DNA than what you need for an industry that moves so quickly that may not use RCTs in the same way to define efficacy or effectiveness. And it has a kind of fluidity to the startup world that's very different from what you see in big pharma. I also don't think you can look to the industry itself to self-regulate, but whatever you do, you don't want to stifle innovation in this space. One of the places where I would push us all to think about is whether there are third parties at Benchmark, which used to be called Advocate, but we've changed our name to Benchmark. We are trying to do exactly that, working to build a marketplace for quality that's quite different from the marketplace we have now. You're going to hear in the panel in just a moment from Caroline Pearson from the Peterson Health Technology Institute about what they've done to begin to look at how to define value. And you'll hear from Sarah Hudson-Scholey as well from Levitt Partners about whether there's a way to use reimbursement, which I think is a super interesting opportunity here to change the way we approach the digital mental health industry. On that second topic of AI being used for therapy, I think the point to make here is that while the generative AI tools, the foundational models we have, can't provide therapy, they can provide psychological support, they can provide a lot of other things, but we're going to need something very different. We're going to need bespoke LLMs that are being developed, and that's happening. There are some that are coming out now. You'll hear in a moment from Nick Jacobson, who's worked at Dartmouth with Therabot. There's a company called Slingshot that's developed a really interesting tool called Ash. This is just starting, but the early data that we're seeing already is that these are really powerful for engagement, which is a huge problem for why digital mental health hasn't been more successful. And they seem to be most effective for the most marginalized populations, which I think is a really hopeful note for all of us who care about equity and why we haven't been able to do more for some parts of the population. So my advice here in terms of policy is don't kill this field before it has a chance to develop. I'm very concerned about HB 1806 in Illinois, which is going to ban, if it's signed by the governor, will ban the use of AI for therapy. I don't think that will stop the large companies from providing what they provide today, which people will call therapy, but it will preclude the development of actually science-based tools that could potentially provide the kind of care that people actually need. If you're in the policy world, you're going to hear a lot about this problem from national organizations that represent professionals who are worried about their jobs. It's the same reason why we don't have self-driving trucks today, because of the lobbying that's taken place to make sure that truckers don't lose their jobs as well. You want to listen to that, but you also want to be able to listen to what are the needs of patients and families who today are left out of the care system. And when you think about what AI can do, you always want to remember that, well, it's not perfect, that the status quo is so far from perfect that we have to be asking, is this better than what we're able to do, both in terms of efficacy and safety with the world that we're in today? So I would urge you to support the use of these tools already for training, for administrative efficiency. The digital scribe can really change what we do in so much of the mental health world to improve engagement and certainly for psychological support, and to think about how reimbursement itself needs to be transformed so that we're actually paying for innovation, we're focusing on outcomes, and we're making sure that this does not continue to be simply a fee-for-service industry. So I'll finish with the quote that I hope you'll find useful, and something that I think is important to remember, and that is that as we think about the policies that we need, we have to be playing chess, not just checkers. It's going to have to be a long-term strategy that understands that we're still at an early stage in the development of this industry, that innovation is continuing at an accelerated pace. And we want to think on a sort of 10-year horizon at least, even though we have to make changes in the near term. So with that, let me turn this over to the panel. I want to introduce Anastasia Glidkovskaya, who will be the moderator for this panel, and I'll be back with you for the Q&A, which we'll have towards the end of the hour. Anastasia, welcome.
Thank you so much, Tom. Fascinating keynote there. Really appreciated the nuanced points that you made. And welcome to everybody. Thank you for joining. I'm Anastasia Glidkovskaya, senior writer at Fierce Healthcare, and I'm excited to moderate this discussion, as you've heard, about digital mental health tools and how they currently are or should be or may be regulated. So first, I'm going to briefly introduce our panelists. And as a quick reminder, we are going to be taking questions at the end. So please drop them in the YouTube chat and we'll do our best to get to them. So first off, Sarah Hudson-Sholey is a principal at Levitt Partners in DC. She specializes in supporting multi-sector alliances to promote improvement in quality, equity, and person-centered healthcare. She recently wrote an assessment of the federal regulatory landscape impacting digital mental health technologies, so super relevant there. Caroline Pearson is the executive director at the Peterson Center on Healthcare, where she leads initiatives focused on creating a high-performing health system that delivers better care at lower costs. Caroline also designed and built the Peterson Health Technology Institute, PHTI, which she launched in 2023 to evaluate the clinical and economic impacts of digital mental health solutions. Welcome, Caroline. Nick Jacobson is an associate professor at Dartmouth College's Geisel School of Medicine, and he serves as the director of the Treatment Development and Education Evaluation Core, within the Center of Technology and Behavioral Health. And he leads the AI Mental Health Lab there, and he developed Therabot, as we heard previously, a Gen AI therapy chatbot that has been built over 5 years. So welcome, everyone. And I know there's a lot of mouthfuls there, a lot of really impressive credentials, and we are going to be talking about digital mental health tools today. So I wanted to start with just a broad definition of what these tools are, the different types of tools there are out there, and the current status of regulation for these different tools, because we know there are prescription digital therapeutics. We know there are remote monitoring devices, there are apps, and they are not all regulated in the same way. So maybe, Sarah, I'll start with you. Can you just give us a sense of the landscape?
Thank you. And it's delightful to be here today and appreciate the support of the Commonwealth Fund for this work that we've done. So when we think about digital mental health technologies, we think about some tools that patients or people interact with themselves. Many of them are consumer wellness apps where there won't be a clinical person involved. Then we also think about the kinds of tools that patients and clinicians may use together, like digital therapeutics, where a clinician may prescribe and work with a patient in using those tools that are designed to diagnose or treat a condition. And then there's a whole array of tools that are used by clinicians or healthcare organizations that can support the process of care. And those are the kinds of things that that Tom mentioned that might help to reduce the burden of documentation or help to train clinicians or help them to recognize patterns of care that might warrant changes in treatment. As we think about the regulatory process, we think sort of the life cycle of regulation. So that might begin with research, and there are federal authorities that support research into digital tools. We think about FDA as the regulator that looks at the access or decides what tools may meet safety and efficacy regulations. But the FDA focuses on tools that are focused on diagnosis and treatment only. So those consumer wellness apps don't fall into those FDA purview. We think about CMS and other SAMHSA, other parts of the government that pay for care, and they have responsibility for evaluating or determining, making coverage decisions. Then, as we think about the implementation and use of these technologies, we think about privacy and security. And so for tools that are that are used in the process of healthcare, then the privacy and security regulations from the Health Insurance Portability and Accountability or Act, or HIPAA, come into play. But many of the tools, especially those consumer wellness apps, don't actually fit under HIPAA. So it's the Federal Trade Commission that has responsibility for making sure that the claims that these solutions make are real, and for addressing any issues around privacy and security of personal data. So you can see that there's a whole array of federal authorities that may come into play, but very few actually specifically address the needs of digital mental health technologies. And what we found is that for many stakeholders, it just seems like they don't fit together, and there are many limitations in the current statutes because as this field is evolving.
Thank you. Well, let's talk about those limitations. Caroline, Nick, you're welcome to jump in, but where does current federal regulation fall short of some of the regulation needed for these tools?
I'm happy to jump in. At PHTI, we often are working with large employers as well as health plans that are trying to make decisions about digital solutions that they want to purchase and make available to their members. And we see a real discordance between the solutions that those big purchasers are considering and things that have been FDA approved. So a very few number of digital mental health solutions have been approved as prescription digital therapeutics. But there's a very large field of applications that are actually very well documented as having strong clinical effectiveness. And they're being rapidly purchased and rolled out to plan members. And so I think, the regulatory bodies are relatively far behind here where the market is. And you just see employers and health plans saying we have such a need that we need to address. So, I think that it's actually important to be looking at what is the evidence for that market and not assume that FDA is really providing significant oversight here.
Yeah, I think similarly, my thought on some of the things that FDA has operated under is considerably right now is enforcement discretion. So there's a lot of things that they could be regulating, a lot of claims that folks are making that are basis on diagnosis and treatment, but they're not really chasing after folks that are making those claims. Because of that, a lot of really digital therapeutics in folks' minds in the industry, I think have become digital therapeutics have become synonymous with prescription digital therapeutics. And I don't think that actually needs to be the case. I think if there were more successful regulation spaces, that this could actually provide some things that are regulated to be over the counter and would be on the upside of actually being able to make clinical claims with clinical outcomes based on clinical data without requiring a prescription. And I think if we're going to actually solve some of the real access issues that Dr. Insel talked about, I think that's going to be one of the vehicles that would need to change to actually make that possible.
So some of this is coming from the statutory authority that the FDA has and what it's able to look at, but it's also what we heard is the challenge between what FDA reviews for and then what CMS might make a coverage decision about. And as Caroline mentioned, CMS is, like other payers, is interested in understanding what's the impact long term, and will people use these tools? And those are different criteria. And so what we find is that some innovators are actually trying to avoid the FDA review, and so that because that won't necessarily create an opportunity for payment, and so. It's these kinds of challenges that led the multi-stakeholder group we talked with to say, you know what, we really need a modern regulatory framework that would address these issues and help us to understand how to increase the use of the tools at the same time as taking into account where there are opportunities or concerns about safety, adverse events, and how to actually understand what these tools do in terms of engaging people over the long term and also improving outcomes.
Sticking with this theme of FDA for a second, Sarah, you've mentioned before that there's kind of an equity issue at play. As you mentioned, the FDA process, not all vendors want to engage with it, given kind of how arduous it is, and it can be expensive. It can take a lot of time. If you're not going through the FDA approval process, then that comes with its own host of issues, questions about safety and privacy for consumers. But if you are going through the FDA process, then you might need to ultimately charge a lot for your product, right? Because you're going through this expensive process. And ultimately, these products might not make it into the hands, at least immediately, of the neediest populations. Can you talk about what you've heard from vendors in this space and why this dilemma exists for them?
Well, part of it is that the FDA review is looking at randomized trials, and so think of it's under the device review at FDA. So it's thinking about a device in terms of a very specific action, like at its simplest, it would be like a tongue depressor, versus what we have in these digital tools is something that's powered by AI that's constantly changing, and the current regulation doesn't apply for that. So they're very high stakes decisions that organizations have to make in terms of how they develop and power their randomized trial for FDA review. And that's where companies face challenges, because they need to make the best choice they can to pass through that review. And that may not be focused on populations at higher risk due to rural urban status or their access to devices or other things. So that's really where the challenge comes into play.
Does anybody else want to weigh in there? Okay, so we've been talking about regulation. What are ideas for federal regulation that could help take into account the different types of tools that we've been talking about? Obviously, the FDA approval process is not right, as we have just talked about, for every type of vendor. Nick, maybe you can share some of your experience developing a tool, but what do you think would be a fair regulation for that type of product, and what agency might be right to oversee it?
Yeah, I don't think there's actually a great spot for it within existing regulatory bodies. I think FDA, as we talked about, is originated for food and drugs, of which digital therapeutics certainly are not. So, I think they're doing their best, but I think in a lot of ways, this does probably require new regulatory bodies to be really formed to actually be customized towards these types of applications in ways that are not trying to take something that was an old law and continuing to adopt it in ways. I think there are a lot of room for new innovation to do this well. I think the direct legislation surrounding this space, I think, is another way that folks are intending to go. I guess the Illinois bill that Dr. Insel mentioned, that HB 1806, for example, within generative AI and providing emotional or therapy support being outright banned with no path to actually access or approval, I think is not the way either in terms of folks. So I do think it does require some new regulatory bodies to do this well. I think trying to continue to adapt old bodies to new areas is just doesn't result in a good fit.
So I think it's really interesting to think about, how the current regulatory process works, but then also what might be needed might not be federal regulation. There may be other ways to solve this issue. But if you look at what's coming out of the administration today, you can see a lot of enthusiasm and interest. There was an RFI on the technology ecosystem out in June. There's currently a proposed rule in the physician fee schedule that asks about what are ways that to address opportunities for digital tools, for software as a service. So I think this is a time when the administration is saying, what is the approach that we need? And it may not be thinking about it in terms of rules and regulations from the government, but or at least not in the ways that we've seen them, but it may be other ways to think about, well, what is the information we need? How can CMS encourage the payment of these services and the adoption of the services? So I think there's really an opportunity today for stakeholders to come together and try to think about, well, what would be a way to make these solutions available, but in a way that it can actually protect individuals from unsafe or adverse events, and monitor for adverse events, but also avoid waste on tools that really aren't doing the job that we hope that they will do.
Yeah. Well, we'll come back to reimbursement shortly, but Caroline, let's bring you in. PHTI recently evaluated enterprise digital mental health tools for depression and anxiety, though you guys did not include AI chatbots in that analysis. And you evaluated their clinical effectiveness and their economic impact. Can you just give a couple of key takeaways from that?
Great, absolutely. So as you mentioned, these are really solutions that are being sold not direct to consumer, but to large healthcare purchasers, whether that be health plans, employers, or providers. And we really looked at solutions that were specifically trained on validated mental health methods, typically cognitive behavioral therapy. And I think there's a number of themes. So first of all, we looked at 15 different solutions. And each of them includes a library of digital content that may include videos, activities, and other modules that individuals can do on their own. They can do these sort of validated mental health tools and activities without a clinician being involved at the point that that's happening. And I think one of the first surprising things was actually that self-guided content was very clinically effective. It produces clinically meaningful improvements in anxiety and depression symptoms based on validated metrics for people who are not otherwise receiving therapy. And so that really speaks to the potential for us to think about digital solutions as ways to expand access to care for populations who may not otherwise be able to access treatment or be interested in accessing treatment from a healthcare provider at that time. So that was very exciting and not something necessarily that we assumed as we set out. The second category of solutions that we looked at were similar in their structure, but they have actually gone through FDA review and become prescription digital therapeutics. And what's important is that those solutions are used in conjunction with other care. So a provider may be giving a patient, psychotherapy on a weekly or biweekly basis, and then recommending that they complete these modules and lessons in between visits. And in that instance, we see that those solutions really do improve symptoms even beyond just regular psychotherapy. So they deliver incremental benefits when they're integrated into provider-led care. And that, again, is really exciting as you think about places where we have a provider shortage, we may have convenience issues, and you can use PDTs, the prescription digital therapeutics, to extend treatment beyond that live provider interaction. And then the third category of solutions that we looked at took all of those self-guided tools and integrate networks of providers. And we call those blended care solutions. But what they do is they allow people to have both self-guided options and then to step up or step down treatment to more intensive levels of care when they need it, including psychotherapy from a provider, but also asynchronous therapy, text-based therapy, chat, et cetera. And those solutions really delivered some of the highest clinical value, and they're being widely adopted in the commercial market today. But unfortunately, they come with very high price tags that do not that increase overall costs. And so I think there's a very important question about how we take advantage of the clinical benefits that were very real here and scale those solutions in a way that is affordable for the healthcare system and for all users.
Well, that's a great segue for us to talk about funding and how to pay for these things. Maybe Caroline, you can start us off, but I'm curious, coming away from this report, what you think are kind of some of the ways forward realistically for these different buckets of tools that you mentioned.
Well, I think the thing that was most exciting about the report findings for me is that for people who use these solutions, not only do they see symptom improvement, but they see symptom improvement that actually reduces their overall healthcare spending in excess of the price of the solution in most cases. So there's savings to be had and clinical benefit to be had at the right price. And so the question, but you have employers that are, very concerned about the mental health of their population and their workforce, that are investing in these solutions, sometimes in ways that are cost increasing because they're paying huge access fees for every employee. And so what we need to do is say, gosh, that's not going to be tenable in Medicaid. It's not going to be tenable in Medicare. And so how can we take advantage of the ability of the technology and this, to drive this sort of digital opportunity for clinical benefit, and then be using our healthcare providers for people who really need it at moments when they need it. And combining the technology and the live providers more thoughtfully will enable us to have a more, cost-efficient solution that really we can begin to expand more broadly. It shouldn't just be available to the well-resourced employer groups.
Okay. Anyone else?
So to build on that, part of the issue is really thinking about what is the that payment strategy. We've seen CMS create codes that do use digital therapeutics. Those are codes for clinicians to provide those and to provide the therapeutic and to support it. But you see that CMS is being judicious in expanding this code, both because there are relatively few FDA cleared devices that kind of meet their stringency, but also, as they asked in the fee schedule proposal, their concern about the potential for waste and fraud. So understanding in a better way the ability of the tools to engage patients, to have them remain in care, and to demonstrate outcomes beyond symptom improvement, I think, and to be able to tie that back to reductions in other kinds of healthcare costs. It's that information on a level footing that we need from these solutions in order to help guide policy.
Caroline, well, as you said, these tools are out there in the market. Employers are really interested, but some of them can get pretty expensive. At the same time, I mean, we know that it's important to use, as you said, clinicians alongside these tools to help democratize access and ultimately make them more affordable. From a payer standpoint, this is to anyone, feel free to answer. What do you think payers want to see in terms of data, whether that's from the vendor, from the provider side, or outcomes in patients, to help make this argument that this is really worth reimbursement?
Well, the payers that we work with are very focused on clinical outcomes. I mean, first and foremost, they want to see that people are getting better. And there are many clinical outcomes that matter, but for anxiety and depression, they are really looking at PHQ-9 and GAD-7 results. And ideally, they'd like to see sort of durability around those improvements over time. So that's first. And then, second comes sort of the payment after that. But I think, they are looking for evidence from both the solution vendors and then also from their own patient populations. And so I think they're getting much savvier at being able to sort of track progress in their own claims analysis as they're going to really demonstrate and feel that they're getting constructive outcomes. Now, I'll just say there's two core ways to make these solutions more affordable. And it's not just negotiating a different price. One is thinking about the underlying technology costs. And that's some of what I mentioned around how can we use technology to expand our human capital and not rely so much on one-to-one therapy, at which point the price of the solution can come down. The second is to get more people engaged. Offering these solutions to a payer population is expensive, but the more people who need help that get help, the more we see in terms of other healthcare savings. And that's where engagement is really sort of the outstanding question here. We still have a lot of folks who would benefit from these tools not using them. And I will say I'm personally hopeful that that's a place where some of the AI chatbots, which are so engaging, we've all experienced how engaging large language models can be both helpful in their therapeutic value, but also in really bringing people into these solutions in a way that they haven't before.
Yeah, I think related to that, I think one of the things that these AI technologies can really do, we've spent a lot of time developing and interacting with these technologies over the last 6 years, spending about 100,000 human hours and really in building tools that are evidence-based, safe, and effective. And I think there are some things that are really important lessons that I think folks are starting to learn in this area that are just jumping in. I think one of the things is that to do this well, it actually requires a really large amount of time to develop these systems, and ways that I think I've seen a lot of companies and industries that are really trying to flock into this area and doing so by just calling prompts to models, to foundation models, saying act as a therapist in various ways, or thinking that they just need the gold mine of data access that's easy to access. And I will say we tried those things too immediately, and they really don't work well in terms of their clinical outcomes, in terms of the things that were easy. So even clinical data, like high quality clinical data, actually was really producing very poor outcomes in practice when we were testing these. And so I think a lot of the way to design these best is really in tailored, developed ways, which from the cost perspective is a downside. It takes a lot of time and investment to develop these technologies to actually be optimally safe and effective. And so from the payer perspective, I think they operate very efficiently and effectively once they start to reach scale. But if you think about developing the cost to develop the technology and you've got, a small amount of people using it, the cost is prohibitive. They only work when they start to scale up, in which case they become actually extremely cost effective given their potency and outcomes. But I think that the downside of taking the shortcuts on trying to optimize for efficiency in the model development is that you are taking dramatic shortcuts in safety, and that is something that is already happening out in the marketplace, but I think shouldn't be acceptable.
Right. Thank you. Well, real quick before we turn to Q&A, I just wanted to ask, as Nick, you alluded to earlier, you believe that there should be new regulatory bodies stood up to incorporate these vastly diverse and quickly moving technologies. I'm curious, Caroline, Sarah, what your perspective is on how moving forward regulators should be considering incorporating digital mental health tools into the broader ecosystem. And this could be ideas for current agencies, state level regulations. Curious your thoughts.
I guess I'll say that I think one of the things that we see as a challenge with the current FDA regulatory structure are really three pieces. First are the evidence standards, requiring RCTs, which of course is the gold standard for evidence generation and sort of is the bread and butter of FDA, is really not how most of the digital health landscape generates evidence, and it is not, I think, necessary in some cases to really understand sort of what the clinical outcomes are for these solutions. Two is really the speed. It's just too slow to meet the pace of innovation. And then third is the fact that these solutions are evolving constantly, right? They're not at a point in time, and so it is hard to sort of give approval and then step away. And so any regulatory solution has to be able to address those three big differences to be responsive to the realities of this market.
And so that really asks the question, so what is the right regulatory approach? And I don't think there's a simple answer to that question. I think this is something where different stakeholders could really sit down and work together to say, well, what are those opportunities? Because those challenges about what's the evidence, how do we, and then how do we judge tools given how much they change over time? I think that's actually a piece of work that requires some attention. And so it's not easy to say, okay, this agency will just start up a new agency to do it. I think it actually requires an intensive multi-stakeholder effort to try to say, well, how could we do this, taking into account what we've been learning over the past decade.
Great, thank you. Now we can turn to Q&A. So I'm just gonna go ahead and pose the first question that we got, which is, how should aspiring clinicians approach and adapt to these changes in practice? For example, how do you see psychological assessments evolving? Who would conduct these assessments? How might AI influence self-exploration in therapy?
So I think in terms of clinicians, there's not enough really to incentivize clinicians to actually want to really engage with these technologies in real ways. It's not sufficiently a part of training programs. I think the number of folks that are trying to actually integrate and adapt with these technologies is really a pretty small minority at this pace, even though there are really a huge amount of value in trying to incorporating many of these tools in ways to increase the efficiency and effectiveness of their care. In terms of the ways that they can intersect, a lot of the different technologies can improve really passive outcome monitoring in terms of having devices that can predict severity of symptoms predict and monitor folks with low burden settings in ways that could actually improve the feedback loop to clinicians to provide more timely care, in terms of the ways that AI can also interact with and develop systems, in terms of ways that they can, it could potentially enhance what the clinician is already saying in sessions, and trying to reinforce those between sessions is, I think, one of the models that folks are interested in this, but also working in ways that are kind of promoting these types of skills before they actually access care, right? So I think a lot of this is, there's a lot of different types of opportunities. There are some agencies that are trying to have training surrounding this within clinical workforces. So the American Psychological Association has done this. There have been others, but I do think that there are ways to try to increase this. But frankly, from the perspective of clinicians, I don't think there are enough incentive structures for them to really ultimately try to adopt these. I think that would be something that would actually benefit more clinical outcomes if we actually had better incentive structures to help clinicians along the way to adopt these tools that could ultimately enhance care.
So I think we've been focusing on the digital therapeutics and the other kinds of tools that patients interface with. But as we look at the workforce challenges in mental health and substance use, I think also use how much these tools can reduce the burden on the clinicians that we have today in terms of documentation, can help reflect back to them what is happening in the visit and how their clients are doing. So there's a lot of opportunities there but they do start with working with clinicians to get used to using those, and maybe part of it is starting with the tools that are around documentation and supporting decision making and shared decision making that can be a way in for clinicians.
Great, thank you. The next question is about general purpose models and generic chatbots. How can we manage those and distinguish between those and actually custom-made large language models designed for evidence-based therapy?
Yeah, in that space, I think one of the ways that they're developed is hugely important. And I guess there are different ways to take that on. One is that these foundation models go through a process where essentially the user will often be asked to select which response that they prefer, and when given multiple options. And then the models then update to try to accommodate that information. This process has got a name called reinforcement learning with human feedback, but the gist is that it's often affirming in the responses that you try to get. So the things that match their internal worldviews are going to be more likely to get recapitulated in responses that way, so they get aligned to try to do this. I think a lot of the ways that you can purpose build these systems is really trying to enhance that their focus on really well-founded, clinically validated concepts that are then deployed as part of the model development and very iterative in trying to develop these systems. I think the way that how do you distinguish between them? It's how they were developed, I think, is ultimately a big part of it, but also how whether they have real outcome data on both their effectiveness, but also their safety. And I can tell you that the foundation models that are out currently available in the open market all act in ways that are profoundly unsafe, even though sometimes they have real moments of high notes where they can perform very well in some situations, but in a lot of ways they don't provide evidence-based care, and often provide things that are directly harmful in ways that I think are unacceptable. But purpose-built tools can show really exceedingly high bars for really producing effective and safe outcomes. So I think a lot of the development and evaluation are the things that can strongly differentiate the two. something that's trained just on the open internet and then reinforced based on human preference is not going to get you to something that really actually works well.
Great. The next question, how can these tools or their policies apply to communities where tech skills are kind of low or there are barriers to technology? The example posed in the question was for the elderly, but I can also imagine rural communities that don't have access to things like broadband would be impacted.
I think part of what we need to think about is not just these tools, but how these tools are part of the care system. So it may be that a paraprofessional could be the one that helps to support individuals in using tools and interacting so that it's not just offered in the wild, but actually through support and with connection back to the care team, whether that's in primary care or in a specialty setting.
If I could just jump in here, Anastasia, it's important to always ask compared to what. So today, 80% of counties in the United States are under-resourced in terms of mental health services. 90% lack any child psychiatry access. So the question really has to be, can any of this do better than that? And is there a way that providing the kind of care that can be accessed for anybody who at least has internet availability get you further down the road? Again, it's not the perfect solution, but it's so much better than what we do today. And we need to be careful to be able to do it well. That's what we're really talking about here, is how do we develop this in a way that actually serves people and not just serves the companies that are trying to get access.
Thank you, Tom. Last question, we have time for maybe a 30-second response. Are there NIMH grants applying these concepts to develop these tools and the corresponding medical supervision? I suppose they're referring to the National Institute of Mental Health. Are there any grants available for development of these tools?
Well, it's certainly
as a
within
former
your
director,
authority.
I can't answer that one. So I don't know what's available in the Institute today. I do know that the Institute is slated, according to everything that I see in the press, to be merged with other institutes. So it's being gutted as we speak. Many of the people who I knew at the Institute have left in the last 6 months. The budget is slated to be cut by something like 40%. So even if there are RFIs or there are announcements out there for funding, I'm not sure that there'll be the funding available to actually support this in the way that it deserves.
Sarah, did you want to add anything?
Well, it's part of the authority, right? So there is statutory authority to do this, but as we look at how the government has changed over the past few months, then I think there's a question about where that focus will be.
Yeah, it'll be really interesting to see what happens. Unfortunately, we are out of time. Thank you so much to everyone for joining. Thanks to our panelists, and thank you to the Bipartisan Policy Center and the Commonwealth Fund for hosting this discussion.
Thank you.